Hi, Hazal.
Hello, how are you?
I'm good. How are you doing?
I'm good. Welcome, everyone. So I'm Hazal. I've been a member of For Youth Coalition for, wow, 6 years now? It's 4 years, 5 years? Yeah, something like that. And I'm originally from Turkey, but I live in France, and I've been working with Women on Web and on self-managed abortions.
Hi, everyone. So I'm Victoria, and I have been working with Women on Web for 2 years. So I work on the help desk at Women on Web. So I'm one of the people that responds to the emails that women and pregnant people send us. And then I also work on a research project for mifepristone as a contraceptive. Um, and I'm from South Africa, and I live in the Netherlands. I studied feminist philosophy, and then it sort of led me to a place where I was like, okay, but now I need to do something to get involved. And then I started studying public health and did my thesis with Murray Stopes, and then came to Women on Web, and now I'm really happy to feel like I really can contribute in some way.
Thanks, Victoria. Then maybe we can just kick off with the first question, and it's a question that we thought might be good to start with, because just to set the ground, what is self-managed abortion? Can you tell us a bit about it?
So at Women on Web, we define self-managed abortion as someone self-sourcing abortion pills. So that would be either mifepristone and misoprostol, or just misoprostol, and then using them outside of a healthcare setting. So not under the direct supervision of a healthcare provider, but hopefully with the support of friends and family, and then really managing that process themselves. But it's important to note that in our definition, we're not talking about other ways of ending a pregnancy. So there are other methods that people use, but often we don't know if they're safe, or we actually know that they really are unsafe. So we're really talking about abortion with pills, where there has been a lot of scientific research done. We know that it's safe. These pills have been on the World Health Organization Essential Medicines list since 2005. And we have really good, well-researched protocols about how to use them.
Thanks, Victoria. And can you also tell us how it works?
Abortion with pills is sometimes called medical abortion, and that's contrasted to a surgical or procedural abortion. So you're terminating a pregnancy using pills. So I'm going to just describe kind of the instructions that we provide to women on our website. So all of these instructions are online, because it can be difficult to remember. And the instructions that I'm giving are up to 12 weeks of pregnancy. If you have a pregnancy that's longer than that, then you should contact us. So to do an abortion with pills, using misoprostol and mifepristone, first you should swallow 1 tablet of mifepristone, 200 milligrams. And then 24 hours later, you put 4 tablets of misoprostol, 200 micrograms, under your tongue, and you keep them there for 30 minutes. The tablets will dissolve, and then you can swallow your saliva, and after 30 minutes, you spit out the remains of any tablets. And we strongly advise pregnant people to use the misoprostol under the tongue. There is other advice that says you can use it vaginally, but we really don't recommend that, because if it's more effective to do it under the tongue, but also if you do end up needing to go to a healthcare provider, then if you've used the tablets vaginally, they can be detected up to 4 days after the abortion. And so if you want to keep it private, then it's better to do it under the tongue. And so then if you've had less bleeding than expected, or you're not sure if the abortion has actually started, 3 hours after that first misoprostol dose, you can put 2 more tablets under your tongue. You leave them there for 30 minutes, swallow your saliva, spit them out afterwards. And you can repeat this up to a maximum of 5 doses of misoprostol. So that's the instructions for the combination of mifepristone and misoprostol. But you can also do an abortion with pills using misoprostol alone. But in this case, you need to have 12 misoprostol tablets. And those instructions are also on our website.
And how is the experience when we take the pills? What do we experience?
Yeah. So when you've just taken the mifepristone, usually women aren't going to have any side effects from that. Although some women do have a bit of light bleeding and a little bit of nausea. But it's really after the misoprostol that you get the bleeding and the cramps. You can also have some nausea, some vomiting, diarrhea, even a little bit of hot flashes or fever. And so bleeding is really it's often the first sign that the abortion has begun. And this bleeding is usually a little bit heavier than a menstruation. And the cramping can also be sort of compared to severe menstrual cramps. And the most intense cramping and bleeding will be sort of 3 to 5 hours after taking the misoprostol. But this process can be different for different women. And it's also important to remember that the longer the pregnancy, the heavier the cramps and the bleeding will be.
One thing that I want to share before maybe leaving the floor to you on this, Women on Web is the first telemedicine abortion service providing help and information to individuals living in restrictive settings from a distance. And actually just yesterday we had one good news that the founder of Women on Web, Dr. Rebecca Gompers, has been chosen among the 100 most influential people of 2020. And one of the reasons for this is that, of course, when Women on Web was there 15 years ago, telemedicine abortion and self-managed abortion was not something that was known that much. Whereas today, she's choosing among one of the most influential people in the world. This year's theme for International Safe Abortion Day is self-managed abortion. So actually, Women on Web fits in a very particular place in that story of self-managed abortion. So how have you been supporting self-managed abortions? Can you tell us a bit about Women on Web?
Yeah, so as you said, Women on Web, we're a nonprofit and we focus primarily on the provision of telemedical abortion. So we were founded in 2005 by Dr. Rebecca Gompertz and some others, and we're a group of medical doctors, activists, researchers, and our help desk. So we support people in self-managing their abortions by providing a safe and affordable online abortion care. So that means when someone needs a safe abortion, they do an online consultation on our website. And then after being reviewed by doctors, the medical abortion pills are provided via mail. And then we provide step-by-step instructions on how to do the abortion with pills, what they can expect, what to do if they have a complication. And we operate in 16 different languages, so French, German, Japanese, Hungarian, Polish. And women can contact us at any time during their pregnancy, asking for information or advice. And up to 10 weeks, we're able to help women self-managed abortion.
Why people choose self-managed abortion? Why is the service needed?
I mean, abortion is one of the most commonly done medical interventions in the world. The World Health Organization estimates that 56 million people are having an abortion every year. And we know that if women do not have access to safe abortion services, that they will voluntarily put their lives and their health at risk in order to end their pregnancy. So we know if a person needs an abortion, they're going to find a way. It's just a question of whether it's going to be safe. And self-managing your abortion is a safe alternative, particularly in settings where there is restrictive access. So pregnant people may choose for a number of different reasons, and that may be because of availability, because it's not available, or because it's not accessible, or because it's actually desirable to manage your own abortion. So we know that there are a number of countries where abortion is illegal and there is no abortion care provided in healthcare facilities. But then, of course, also cost can be a barrier. So in a country where perhaps there are services available in healthcare facilities, but the costs are prohibitive, that women and pregnant people just can't afford it. And then scheduling, pragmatic things that obviously affect people access healthcare. So scheduling, can you get time off work? What are you going to do with your kids? Transport, how far is the healthcare facility from your house? And then self-management is a really good way to manage stigma and privacy. So if you live in a small place and there's only one healthcare provider there and you don't want them to know, then this might be an option for you. And then domestic violence, so where a person needs to keep their pregnancy and their abortion secret from a partner or from family. And then, of course, preference, because some people just want to do this in their own homes, in the comfort of their own homes. They don't want to be in a clinic environment. They want to have control over the process, know what's happening with the process and with their body.
Thank you, Victoria. Does the procedure requires a medical follow-up?
In most cases, there will not be a requirement for a medical follow-up. So if there are 100 abortions done, then between 2 and 3 women or pregnant people will then seek medical care after the procedure. So we always advise that it's important to have access to a medical facility within 60 minutes in case there is a complication. But these complications are incredibly rare.
Okay, thank you. And then for people whose abortions fail or not complete, what do you advise?
Maybe we should talk a bit about what those complications might be. As I said before, they are extremely rare, but the things that we ask pregnant people to look out for in terms of complications are heavy bleeding. So if you have bleeding that lasts, heavy bleeding that lasts for more than 2 hours, or soaks more than 2 maxi sanitary pads, or if you're feeling dizzy or lightheaded, or if you have a fever, so that would be a fever of more than 38 degrees for more than 24 hours, or a fever of 39 degrees, then you might have an infection. And that might be caused by tissue that is left behind in the uterus, which may then become infected and cause a spike in fever. And then in terms of infection, you may also notice some discharge, strange smelling or strange color discharge. And then also the third thing to look out for is pain, if you have ongoing and persistent pain. And in all 3 of those cases, if you notice any of those, you may be experiencing a complication, and we would say then you need to seek healthcare immediately. And you don't need to tell your healthcare provider that you've had an abortion. You can say that you think you had a miscarriage, because the signs and symptoms are exactly the same, and there isn't a way that a doctor can detect that you have actually caused an abortion.
One of the questions here, which asks if self-managed abortion is a safe option for women who live in areas with no access to a hospital.
It's important to understand what the abortion pills actually do, and that abortion pills cause a miscarriage. And so the risks associated with abortion are the same as as a miscarriage. And because miscarriage is such a common occurrence, 15 to 20% of pregnancies are ending in miscarriage. And so healthcare providers are really well equipped to deal with the complications of a miscarriage, which are the same complications that you could get for an abortion. So that means you don't need to have a big hospital available to you. If you have a small healthcare provider somewhere close, that healthcare provider is probably trained and is capable of dealing with the complications. So yes, you do need to have access, but it doesn't need to be a big medical facility.
A person who needs help, I don't know, contacts you saying that she suspects a pregnancy. So how does it work? Can you walk us through the process?
Of course. So if you suspect that you're pregnant, the first thing that you want to do is get a pregnancy test. So you can usually get a pee on a stick or a urine pregnancy test from a pharmacy for a relatively small amount of money. And then if you are pregnant and you decide that you want to self-manage and you want to go through Women on Web, then you would go to our website, www.womenonweb.org, and you would then fill in an online consultation. And that's 25 questions that are about you and your health. And the reason we ask those questions is the doctor can then assess your case. And we then ask for a donation, and this is of between 70 and 90 euros, and we use this to maintain the service, to continue to be able to provide services. But we understand that for some women that's just not a feasible amount of money, and so we always try to provide services to women irrespective of their financial situation. So then the doctor will assess the information you provided and see that there are no contraindications, no health conditions that might put you at a higher risk. And also make sure that your pregnancy is within the 10-week period that we are able to assist women. And then they'll write a prescription for your case. That prescription gets filled by a pharmacy that we work with. And the combination of mifepristone and misoprostol will be sent to your home address. And then we'll provide all of the information you need, step-by-step instructions on how to do it, what to expect, complications. And then at any point during this process, if you're having any concerns or worries, you can always email the help desk. We always respond within 24 hours.
Mm. Thank you, Victoria. Because there, I think this is important because I guess there is always this image of self-managed abortions that it's a very lonely experience. Of course, it can be. I mean, countries where abortion is restricted, where it is such a big stigma, and already, I mean, abortion in many cases in many countries, even where it is legal, yes, it is an experience that kind of is done a bit in isolation, and people don't share it, and that's why we kind of try to challenge it with Women on Web. We invite people to share their abortion stories, and kind of you have this help desk. If you are managing your abortion through with Women on Web, then you also have this correspondence with the help desk, which works in 16 languages, as you said, that they will always get back to you within 24 hours. There is this one question about kind of more about the role of follow-up counseling for women who had abortions, especially in conservative societies. What do you think about the role of counseling after abortion?
I think that for some women, this will be something that they want. And for some women, it is not something that they want. And I think it should be available to those women who feel that they need more support. But I also think that, you know, for some women, it can be intrusive. It's not something that they desire. And, you know, it's not common for other medical procedures to have counseling attached to it. But of course, working on the help desk, we do see that women really, I think that they really benefit from having someone go along the process with them. But I also think, in my experience, that it's more before and during that women want assurance, but also information. You know, it's not necessarily a psychological support that we provide, or that maybe women are asking for, but having information and feeling safe in the process and in the outcome, I think really helps women.
Yeah, and do you think there should be a difference in terms of in your approach, or does it exist already for self-managed abortions for women with little to no access to emergency contraception?
No, we provide information to women in any situation. Our approach to Women on Web is that we trust women. We trust them to be able to make good decisions about their own bodies and their health. And information is free. This is stuff that is widely available on the internet. It's well researched, and it should be, in my opinion, it should be something that is provided at primary school sex education.
Yeah, which is unfortunately not available in many countries. Just because we were talking about contraception, then I would also just point to this question that was asked. I guess it is in Honduras that contraception, emergency contraception, is illegal, and so the question is, how would you educate people who's influenced by this belief?
We know that women are going to take care of their reproductive lives, whether it's legal or whether it's illegal, and then it really becomes a question of do we want women to have to be putting their lives and their health at risk in order to take care of themselves. So women are going to figure this out, and we see in the history of how this has evolved, this is women taking it into their own hands, and so it's going to happen whether it's legal or not. It's really just a question of safety.
One thing that we have been very much kind of focusing on within Women on Web, for example, in many of our campaigns, is really showing the reality on the ground. Restricting abortion does not stop abortions from happening, it just renders them unsafe, and there are still many clandestine and unsafe abortions happening, or people purchasing abortion pills online. Because of the fact that abortion happens very much in isolation, and it's not something that everyone wants to talk about. People don't know about it, or it's easy to ignore. But just, showing the reality of abortion or contraception, just saying that, well, it is illegal, but this ban is not working, and there are this number of people who are still trying to access to this service. So it has to be legalized. You have to grant access because you cannot fail these people, and it's basic healthcare. Today we have enough scientific evidence and many kind of international documents, conventions, and even advocacy tools that we can actually use for such advocacy projects or service provision efforts that we have. But I would also very much like to hear from you if you could kind of talk a little bit about the history of abortion with pills and self-managed abortion to us.
with misoprostol, it's a really interesting story that it had been available internationally since the early 80s, and it was used for the management of ulcers. And on the box, so this was in Brazil, that a Brazilian woman saw that on the label for misoprostol, it said "do not take when pregnant," and they noticed this, and they started to use it to cause an abortion and started to spread this information. And then there was an epidemiologist who noticed that there were a lot fewer complications from unsafe abortions. He noticed it the next year again, and then he figured out, he must have spoken to women, figured out what they were doing, and that's actually when the scientific research started. So it was something that women found themselves, and then it was later brought into the universities, and it was studied as an abortion medicine. And then with mifepristone, that was discovered, also a kind of inspiring story, discovered in 1980 by Roussel Clough, which is a French pharmaceutical company. And Beverly Winkoff, she tells the story of how this happened on this really incredible podcast that I want to encourage everyone to have a listen to. It's called the Self-Managed Abortion Podcast. And she tells the story of the development of mifepristone. And she talks about how when the molecule was first discovered, that there was already this kind of aura of self-management around it, even in the 80s, because, you know, many women couldn't get access to abortion because it was only where there were health services. So if you couldn't access if there wasn't a health service, a hospital or a clinic near you, then it meant you couldn't get an abortion. And this was the idea that it's a pill. It can go places where medical services can't go. First, it was registered in France, and then a few years later, the company got cold feet, and for political reasons, they wanted to withdraw the drug from the market. And then there was this really famous response by the French Minister of Health, where he said that the pill was the moral property of women and that they could not remove it from the market. Mifepristone and misoprostol have been used for a number of decades only in the context of a clinic or a hospital, so under medical supervision. And this is often highly regulated. And as we discussed before, there are lots of barriers to accessing healthcare. Yeah, either it's not available or many regulations around how you can use it in a clinic. And so telemedicine is a response to that. And so Women on Web was founded in 2005, as I said, and we started providing the service online. And it was in 2008 that the first research was published showing that this was actually something that could be safely done. The self-management is safe, and it is actually as safe. There's a lot of research that shows that it is as safe as doing an abortion in a hospital setting. And then we saw this year that the World Health Organization recommended the expansion of telemedical services, telemedical abortion, and self-managed abortion up to 12 weeks. Yeah, it's the theme for this year's Safe International Abortion Day, and I think it's really changed how people view it. You know, it was sort of something that was seen as not the ideal way, and now I think it's becoming something that is much more normalized, both for providers and for policymakers and for pregnant people themselves. So I think it's really changed very recently, and I think because of COVID, you know, COVID has really done a lot in terms of how we are starting to see self-managed abortion, and it's been, I think, pretty quick the way that it's changed.
Yeah, it always makes me question kind of the intellectual curiosity and the scientific curiosity, because this doesn't exist without people who need the services, and then who kind of try to find themselves kind of a method to do that. So it's really, you know, you need a push to even to have scientific research. Simply no one taught how to make abortions easier. I recently came across to this book called The Abortion Pill. In the cover of the book, it says the most controversial discovery of our times. I mean, it has been a game changer, right? We talk about safe self-managed abortions to a great extent thanks to medical abortion pills.
But it's referred to as the atomic bomb of medicine, that it really caused that kind of revolution.
And it really kind of changed our reproductive lives. And we can maybe just talk a little bit about COVID as well, because I think it is very significant how in this moment of crisis, many governments and many international organizations came to realize that, for example, what Women on Web has been doing for 15 years and all of the claims that we have been putting in terms of, and the research, of course, which is very important because there we had the scientific evidence where we have been saying, well, telemedicine, abortion safe, individuals can self-manage their abortions, is now the recommendation of World Health Organization. And also within the COVID-19 context, many countries like France and the UK, they allowed telemedicine and individuals to take medical abortion pills at their homes. What does it mean for the individual? What does it mean for the abortion experience itself, that now it's with pills and then that we manage it by ourselves?
I think it can be a much less invasive experience managing it yourself. I think maybe it's also important to say that we are not saying that we don't want clinics to be available. We really do want women to have as wide a choice as possible, and also that clinics provide many other services for women that can be added onto an abortion service, and they are also, I think it's also important to have places that women can go to if they actually do prefer to have in-person care, because that can be more comforting to a woman. So it's not that it's an either or. For us, it very much is both. But I think that on the one hand, it really is about empowerment. It's about saying, these are my pills, this is my body, I understand what's happening, and I'm in control of it. It's not something that is so foreign to me. What's happening in the body is relative. It's a relatively simple procedure that women can understand, and also that it's not something that is being controlled by a doctor or being controlled by a healthcare system, and it's also certainly not something that's being controlled by a state. For something that for women has for a long time been about fear, about stigma, about hiding. And it can now be something that if they want it to be private, it is private, but it can also be something that is being reclaimed.
One thing that I've always been thinking when it comes to abortion experience, but it's very difficult to standardize things. Sometimes when I read on the internet or here and there about no, abortion is very traumatic. That is one experience, but there are also many other experiences. But I always resent from kind of making it a standard experience, because it really changes from one person to another. But at the same time, having options is a big thing. I remember once at Women on Web, and I never forget that email. It was a woman from Nigeria who received help from Women on Web, and I remember her email that she wrote. I received the pills, I kissed them first, and then I took the pills. Some people feel that it's their destiny in their hands, and having that power. Not everywhere that you go to a clinic and then people explain you the entire process, right? No. And some people might prefer not knowing the entire process, of course, but really some people would like to have know what's going on. And I guess that has also been one of the missions of Women on Web, really unpacking the language around medical abortion, really telling, well, this is how it works. And you explained us very well in a very clear way that, well, it's not that more difficult than taking any other pills. You explained there is a protocol, then we follow it. Of course, it has risk of complications like in any other medical procedure, what to do in case of complications, or how to manage pain and all that. But I mean, well, it's really you taking control of the process. There is also a lot of discussion about, for example, over medicalization of birth, right? Management of miscarriage, self-managed abortions kind of paved the way a bit to demedicalization, and kind of it challenges somehow that medical hierarchy. If I do my abortion, do I have an abortion provider, or am I my own abortion provider? And what does it mean if I am my own abortion provider?
Yeah, because abortion is about autonomy, and this is now providing, I would argue, even more autonomy. I really like that that phrase, I am my own abortion provider.
Yeah.
Yeah. As you said, for some people, having an abortion in a clinic can actually feel, some women may have the feeling of giving over control to someone who is skilled and feel very comfortable with doing that.
Yeah.
and feel, you know, that they don't have to think about it. That there can be some comfort in being in a medicalized environment. Every woman, I think, has their own experience of abortion. It's this incredibly individual experience that is, and for many women, it's quite a big experience in their lives, and it has a lot of weight. Whether it's a happy experience or a relieved experience or an empowered experience, I think it often does have a lot of meaning. And but it really is such an individual meaning.
It also has this big potential of increasing access to abortion, especially where delivery sites are not are not enough. I mean, and this is already a problem in countries where abortion is restricted, but also in countries like like Canada, where abortion is legal, but the delivery sites are very far, and travel and scheduling is very difficult.
How has COVID actually affected Women on Web and Women on Web's provision of telemedical services?
Women on Web works in countries where access to abortion is restricted. And these were the countries where we received the most emails and help requests. So what happened with Women on Web within the COVID-19 situation is that we also started to receive help requests from countries where abortion is legal due to various reasons. Even if it's legal, it was far. People had to take care of their children now because the schools were closed, so they couldn't schedule an appointment at a hospital because they had to they had to take care of children, or they were simply afraid to go to a clinic because of fear of contamination, which is also very valid. During the lockdowns, we had moments in Italy, in Spain, that all of the medical personnel was mobilized for the COVID-19 response, that abortion services were not available anymore. So we also started to receive help requests from those countries. And then that was also kind of a new thing for us, because normally when we receive help requests from those countries, we would refer them to local options. But then when we referred them to local options, we saw that they are also not available anymore. So, there again, we saw, well, we are needed. Telemedicine abortion is needed actually to ensure access to safe abortion all the time, but definitely during a pandemic. So that was one thing that we came across. And this is for the countries, where abortion is normally accessible. But for countries where abortion is already restricted, an issue, one of the challenge is that usually in these countries, abortion bans often really hit the people from lower economic background the most. And that is what pandemic does as well, right? And we knew that, of course, access to abortion is problematic, and there are many problems of access. But at the same time, with the pandemic, we saw that everything is now worse. So kind of the pandemic made the problems of access more visible, and it reinforced them, unfortunately, as well. Because normally in these countries, there are people who offer clandestine abortions at very higher costs. This is a reality of many countries, and many people lost their jobs, so this wasn't an option. In many countries, especially we have that a lot in Europe because it's a smaller continent, in a way, many people travel. Like, for example, if you need abortion and you live in Malta, you would maybe travel to Italy or to the UK to have access to abortion. Or if you live, let's say, also in the Middle East, we have that phenomenon in a bit, that if you are from Lebanon and you need an abortion, you would go to Turkey. That wasn't an option as well, because the borders were closed. People are not able to afford, they are not able to travel. So it really kind of made all the problems worse. But it also showed us how important telemedicine abortion is. And I think that's also came to the entire world realized that. And that's why we are talking about self-managed abortions today. That recognition is important, because now, for example, telemedicine abortion was legalized in France during the confinement, and then they changed it back. It was legalized in the UK, and the process still continues. So you can still have an abortion through teleconsultations there. But in France, they changed the regulation. So it was a temporary regulation, and they changed it back. And I think it is also significant for our advocacy works, and that's what we would try to do. We would try to ask, well, if it was possible once and you allowed it once, why do you take it back? On what grounds? What COVID-19 did for telemedicine abortion is that it really, telemedicine abortion in this whole picture, it's really the silver lining. It became mainstream all of a sudden, and it is because we saw how it is very much needed.
Yeah, I agree with it, that COVID really showed the problems, but it also showed the solutions.
Yeah,
for
exactly.
managed abortion or for abortion provision. When you've been working in Women on Web for a long time, how long?
8 years.
8 years.
8 years, yeah.
Um,
You know.
what is your favorite thing about working for Women on Web?
Really solution oriented. And the reason I say this is because we encounter many problems. You know, our website is banned in various countries, for example. We still need to reach people, and then we kind of try to adopt alternative strategies for this. And one thing we did, for example, we developed an app. It's called Safe Abortion, and you can download it on your smartphones or on Android. It's available on App Store and Google Store as well. If your country bans our website, you can change your location, download these apps, and then use these apps to ask for help at Women on Web. We made sibling websites. It has a different name, but when you go, you still make consultation at Women on Web and you receive help. So that was all kind of a way to provide help. But of course, we don't always think that short term. We also challenge these governments, and I think that is also very important. We kind of, I mean, we do at the moment we have a legal lawsuit with the Spanish government, who banned our website, unfortunately. We will do for South Korea, or we will do for Turkey, who also banned our website. So we really challenge these things, but also provide solutions. And I think I really like that way of thinking. Yeah. Can I also direct this question back to you?
Sure, yeah. So I work on the help desk, and that means that I'm answering emails from pregnant people all over the world. I think that doing this work, writing these emails, our service is very much based on compassion and care, and I really like being able to practice that in relation to the people that we serve. So it makes me feel very connected. It's a very human experience, because some of the people that we talk to are very vulnerable, and then we respond to that. And we're sort of kind of unconditionally trusting and compassionate. And I like that, sort of having to like ethically orientate myself to people in that way, and recognizing that that's the basis of our work. That's why we do this work. And it's sort of from that perspective, that understanding of how people are, that we understand why people should have this kind of autonomy. So it feels like it's a sort of built-in reminder of why we're doing this work.
I see that we have one question. Is there an upper or lower age limit for medical abortion, either medically indicated or within your policy?
Mm-hmm. So I actually don't know if there is a medical indication. I wouldn't be able to answer that, but within our policy, we do not have a limit. We do recommend that if we do have younger people trying to or accessing our services, so if someone is below the age of 16, we encourage them to get in touch with someone who might be able to support them, because it can be a difficult process if you are young and managing it on your own. But again, we trust women. If someone doesn't want to carry a pregnancy to term, then we would support them in that, irrespective of what their age is. We just want to make sure that they have the best support that they can.
Yeah. Also, for example, sometimes it's, let's say, the parents who are contacting us on behalf of the person who needs help, who is, let's say, below 18. And in that case, actually, I mean, we always we advise that person to have an adult with, during the process, but at the same time, we make sure that we talk to the person who is in need, and not the mother, the father, or whoever. It's almost been an hour. I don't know if you have other questions or if we should end it here. I mean, already thank you very much for all the questions, and thanks, Victoria, for all these answers and for this conversation. And once again, big thanks, of course, to Asmita and to Youth Coalition for hosting this live chat with us. So it's a pleasure for us.
I want to say one more thing about, I'm sure that everyone knows where our website is, but if you are interested in learning more, our Q&A section really is a treasure trove. Many things that you might think about asking or that you haven't thought about asking. And then one other thing I think that is becoming more relevant now is that Women on Web provide services in many places, but unfortunately we are unable to provide services in the US. Or women and pregnant people who are based in the US, there is also a service that we can recommend called Aid Access.
Perfect. Thank you very much, Victoria. Thanks, everyone. And bye-bye.
Bye.